the chair of this committee. So I thought, since this is the first of our public meetings for the Primary Care Commissioning Committee, we'd go round and introduce everybody. So I'm going to start with those voting members. So Les, Jonathan and Karen is not here, I understand, sends an apology. So perhaps Les, could you introduce yourself?
I'm Les Ross, the secondary care doctor on the governing body.
Jonathan?
I'm Jonathan Bates. I'm one of the executive directors with responsibility for planning, performance and delivery, and also the primary care SRO. And then Andy, do you introduce yourself?
Good morning, I'm Andrew McMyler. I'm the Director of Primary Care for the CCG. And
Nicola, you're on the call, I believe.
Morning, hello, I'm Nicola Jones. I'm the GP clinical lead at South West London.
We've got William. You want to introduce yourself?
Yeah, I'm William Cunningham-Davis. I'm the Deputy Director of Primary Care for South West London.
We've also got on the call representation from Health Watch.
Yes, that's me, John Anderson.
And CVS.
That's me. I'm Bruno Meekings, and I'm patient voice representative on behalf of the voluntary sector.
And James, you're on the committee as well. Would you introduce yourself? James Blythe.
James Blythe, Locality Executive Director for Merton and Wandsworth.
I think we've also got representations from each of the boroughs, is that right? So Sutton, do you want to introduce yourself from Sutton?
Hi, I'm Sian Hopkinson. I'm Head of Primary Care in Sutton.
Are there two of you from Sutton, did I see?
Good morning, it's Lou, Deputy Head of Primary Care, just observing this morning.
Okay, right. Wandsworth?
Hello, I'm Katie Bugler. I'm the Deputy Director for Primary Care for the CCG, but specifically for Merton and Wandsworth.
Okay, so you're covering Merton as well as Wandsworth today, right? Okay. Richmond and Kingston, is that joint or is that?
It's me, Susan. It's Tanya ID's Locality Executive Director. My head of primary care is off this week, though. It's Omid would be here as well usually.
So you're covering both Kingston?
Yeah.
Lovely, thank you. Croydon.
Yeah, that's Mark Creelman here. I'm the lead for primary care in Croydon.
Lovely. Now, I'm sure I've forgotten something. Let me just check. There are some people listening in on the call, so the Health Watch have been invited to come in and observe. As in addition to John, have I missed anybody that I should have mentioned? Anybody else want to introduce themselves? Lucy, hello. Are you here?
I'm here for Sutton.
Okay, welcome. Okay, good.
Hi, Susan. Can I introduce myself as
well?
Yeah, sorry. Assia Yunus, I'm one of the medical directors at London Wide LMC, Merton and Sutton and Wandsworth.
Beg your pardon. Thank you very much. Thank you. Good to meet you. I've only got 9 pictures that I can see, and I'm not confident that my technology will see your electronic raised hands. If you're on the screen and you raise your hand, I will see you. But actually, if you could show your desire to speak, if I haven't asked you to, in the chat room, I'll keep that open and keep an eye on that. So I think that, and Andy, if you spot anybody who wants to speak that I haven't noticed, then please let me know. Okay, just note this meeting's being recorded and it'll be uploaded onto the website. So shall we move on to the agenda? Thank you very much. Could I first check declarations of interest for members should be on the papers, and included a glossary of terms for anybody, members from the public. Quoracy is 3 of the 5, and we have Les, myself and Jonathan in attendance today. Can I just check, is there any other declarations that we should note that haven't been recorded? Or amendments that should be made? If there are any amendments, can you send them to Yvonne for future reference? Okay, thank you very much. We should normally also have an independent GP on the Primary Care Commissioning Committee, but the process of recruitment is still ongoing. You can imagine it's quite difficult to do that at the moment, but hopefully we'll have an additional member joining us later on in the year. Okay, shall we move on to the reports? The first one is actually a report of the meetings that we've already had to date, urgent decision-making meetings of the Primary Care Commissioning Committee, and due to the the social distancing requirements and the urgent need to support a general practice response to COVID, we've had a Choracy represented to meet to consider some recommendations for some decision, and we've listed those in there on all the issues. And now, rather than talk about those particular issues, I think some of those will be evident in the presentations later in the meeting. So if we're happy, are we happy just to note that? Anybody got any problems or questions they want to ask? But this is just important that we register that we have had these urgent meetings and these are the decisions that we've been making. Any comments anybody wants to add? We're all happy with that? This is tremendous. It says 10:20. I should be on the next item, and I'm already ahead of time. So this is so you'll be very pleased to see that we're being very efficient today. Okay, great. Then we move on to the one of the main topics of our meeting, and that's the primary care governance arrangements. I think, Andy, are you going to talk to that?
Yeah, thank you, Susan. So this is to discuss and to note. I think this is a paper or an updated paper that's been to all of the legacy CCGs, primary care commissioning committees, certainly in January and February time. I think one of the things just to note is that this really describes the kind of the business as usual state. As we all know, we're currently operating under a level 4 incident, which is essentially command and control from NHS England. So normal delegations to boroughs aren't in place at the minute, which is why we've had to have primary care commissioning committee to meet under the extraordinary terms of reference just to agree a number of matters. And so what this paper essentially describes on the back of that is just how we would typically operate under normal times. The paper is in 3 sections. The first bit is just about the primary care governance, which is a description of how the governance operates at the local level, and particularly with primary care management groups in each of the boroughs. I know obviously it's joint between Kingston and Richmond as well, and it's to really articulate certain in the second section the decision making. So how, usually according to what's called standard operating procedures, decisions are made or discussed in principle, and also the relationship with the local borough committee. And then likewise, the table in the middle really starts to describe a whole broad range of functions across primary care in terms of what decisions and discussions are had and at which level. So hopefully it's a helpful guide that we can then keep referring back to throughout the year and throughout the cycle of business as well. And then the third section is a range of terms of reference. So one is to particularly note for the South London Primary Care Commissioning Committee, which is essentially pretty much identical to the legacy CCGs, because we're still a CCG, so all of their responsibilities still very much ring true in that regard. And what I've determined is a base model terms of reference for local primary care management groups, which I know that local PCMGs are currently just adapting those to their needs, particularly around the membership. And then what I thought would be helpful, particularly as this is a meeting in public, is just to flesh out some of the questions, the sort of the FAQs that we gave to our member practices ahead of the merger vote last autumn, just so people can really start to understand how all of this mechanics under one CCG fits together. So I will pause there, and then I will have a separate conversation just around the cycle of business agenda item as well.
Can you just clarify, Andy? So the Primary Care Commissioning Committee for this CCG perhaps has had a slightly different terms of reference to the ones that people might be familiar with in the legacy CCGs. Do you just want to elaborate on the differences?
So I think it's probably,
hear that.
Yes, I think it's probably 99% similar, because the statutory functions remain, because we still are, of course, the CCG as we were 31st of March as well. I think obviously what has just changed is the membership has been tweaked slightly. I will say that the terms of reference were developed with extensive engagement of Surrey and Sussex LMCs and London-wide LMC, and also went through CAP 6 lawyers, and I think the NHS legal lawyers as part of the application process. So essentially the terms of reference are to make sure that as a CCG, we can discharge our stated duties around primary care commissioning.
It's just that some of the CCGs in the legacy organisations also covered primary care strategy and commissioning in a broader term, but that is actually delegated or left to the boroughs because they need to do it in the context of their place-based plans. Yeah. Is that right?
Yes, so I think in the legacy CCGs, I don't think strategy was ever formally articulated in terms of reference. I think it was just more about how the previous committees chose to function. And I think one of the things that would be valuable for us to talk about under the cycle of business is about how do we, at a CCG level, wish to be aware of and involved in some of the strategy work that is ongoing. So perhaps having a focus item each meeting to talk about one or two of these issues in some depth So we've got a kind of a broad picture of what's going on across the whole CCG, but very much the local designing and doing happens at borough level.
Jonathan, did you want to add anything, or should we open up?
Yeah, I suppose so it's really helpful to have the papers. They're obviously follow the statutory duties that the CCG has in place. I think it is, of course, worth reminding ourselves that we're in a level 4 incident as defined by the NHS, and a lot of the abilities to delegate decisions to local levels have not been ceded to us through that level 4 process. So, for example, a lot of the financial decisions are being made at an aggregate level across southwest London, or indeed at a London level rather than at a local level at this point. So whilst this is absolutely what the membership practice is voted for, it's the right constitution, it's been steered through appropriate legal advice, etc. It's also worth reminding ourselves that not all of this is enacted in quite the way we would like it to be at this point, because we're in the current pandemic and with the consequences that has. So I just wanted to add that flavour to things too.
Does anybody want to ask any questions? Or yes, Andy, you wanted to say something else?
Just maybe perhaps helpful if I just explain the sort of the primary care governance structure we have at the minute under the level 4 incident, just to kind of help give a little bit of meat to the bones we're going to have a conversation on soon. So what we have and have had since really the start of March is a primary care cell which sits under the overarching command and control structure. And I know this was discussed in a meeting in public on the 20th of May by the governing body as well, so I won't go into too much detail. We have a primary care cell which involves senior representatives, including clinical representatives from each of the boroughs. And the purpose of the cell is to really help support and coordinate the general practice response to the pandemic. Obviously, as you can imagine, we have an awful lot of guidance and directives from national to make sure that we are adhering to in a consistent manner. And where we've had to have a meeting under the Primary Care Commissioning Committee, the 3 meetings that we alluded to earlier, was very much around ensuring that funding to primary care, because we recognise wanted to support primary care and that was over and above their core contract, needed that governance that the Primary Care Committee can bring in terms of its impartiality around conflicts of interest and value for money. So that's the structure that we have. We still have this structure running as well. It's proved very useful to make sure that our practice respond in a very thorough and very resilient manner to the pandemic so far. But I know we'll talk about some of those specific examples in a short while.
Any comments from the boroughs in terms of I think we'll cover that later, won't we, in terms of the development of the primary care management groups, in terms of how they're working. Any questions on the governance? Are we happy to just note those documents and hope that one day we'll be able to fulfil them? Yes, John, you wanted to.
Yes, I do. The Health Watch is at this committee, and that's very welcome. I want to make a general point, then perhaps if it's the right time, Susan, raise a more specific point. But the Health Watch is at this committee, and that's really very important. At a time when primary care is at the front line of change, we think it's really important that public and patient voice is heard at all levels of the system, and in primary care we feel particularly strongly that should be the case. Now, we understand that the NHS is in a level 4 command and control situation and things are not functioning just quite as normal. Nevertheless, there's a detail on page 31 of the pack about where Health Watch does and doesn't fit in, and I wanted to raise that now. Maybe you want to take that point later, but I do want to say that the generic terms of reference for PCMGs omit Health Watch, which we can't really quite understand. And in fact, in Kingston Enrichment, we are represented on our PCMG. So there is an issue about the way in which PCMGs are involving or not local Health Watch colleagues to make sure that public engagement happens. That might be especially important right now when the borough committees are not operating quite as was originally planned.
Well, perhaps we could hold that thought, and then when we come to each of the boroughs' reports, we could reflect on the approach to hearing the the local voices in that process. Are people happy with that as an approach? Would that be helpful, John?
Yeah, could I?
And then you get your specific, or do you want to just talk? I mean, in general, at the moment, it's we're only just talking about this at public meeting, really. But
sure, we're making a general point about the way in which Health Watch should be involved in fully at all the levels of primary care, in particular.
Okay.
And if I may, just since I'm at it, because the boroughs may want to comment on this specifically, we're also we'd like some clarity on whether PCMG's meetings will be held in public or not, if that's possible.
I mean, as far as I'm aware, they're not a public forum, and that's part of our constitution. This is the public forum. However, I think the network that you have locally is very important, and unless anybody's got anything they want to add now, perhaps we could get the boroughs to reflect back on how they see that's going to work, if that's all right with you. Okay.
Fine, thank you. Yeah.
Great. So we happen to note that, sorry, does somebody else want to?
Sorry, Susan, I just had a point to add to that. I think that we're in this level 4 incident for an indefinite period. We don't know how long it's going to last. So I think there might be some point further on to review actually how the structure has worked, because some of the stuff which might answer some of the Health Watch concerns might have emerged were it not for the fact that we were in this level 4 incident, but we can't be sure about that. And there's a need to understand learning from the way that each of the boroughs are actually managing to operate the current structure as it is, I think.
Okay, thank you. Right, any other comments on the particular paper on governance? Andy, did you want to discuss the cycle of business agenda items as well?
Yes, thank you. Yeah, so this again, just for noting. So on page 35 of your 90-page document now. So down the left-hand side, obviously this looks better in landscape, so apologies. But we've got sort of the items that with how we're proposing to structure the agenda of future meetings. So we'll necessarily go through them all, but just to bring 2 or 3 to your attention. So what we will clearly be looking to do is where we have a contractual item that requires approval. I've just listed a couple of examples, but the full details are in the terms of reference. So, for example, if you wish to ratify a new locally commissioned service, or perhaps there's a major contractual action we need to take, then we would expect a report to come to this committee meeting so that we can approve or ratify as required. And aside from that, I think as we are hearing today, we're just taking for noting any specific primary care management group or indeed local borough issues. And I think one at the bottom there, strategy, planning, policy. I've just suggested a couple of topics and various future meetings that we may wish to do a deep dive into. So no, Susan and I have had a conversation about a future meeting talking about the strategy. So what is the primary care strategy looking like for the next 2 to 3 years? It's part of the long-term plan. I think we probably also want to have a conversation maybe about quality. So how do we look at quality surveillance in each borough, and what does that mean on the South of London level? So I'm anticipating, I know we're talking about COVID today as an in-depth discussion, but I think in future meetings, we'll just agree a specific focus area each time, as well as the regulatory work we need to conduct as well.
So just for the minutes, we're noting the content of the governance paper and we're noting the business cycle that's developing.
Yep.
Anybody got any questions for Andy? No? Lovely, good. Okay, well, thank you very much. And now we're going to go into that discussion now, the deep dive. Nicola, kindly, I think you're talking us through a paper on the work that you've been doing in primary care in response to COVID, is that right?
Indeed, thank you very much. So we are looking at the slide deck, so starting on slide 35, if you want to follow. So I won't put the slides up really. What I thought I would do is perhaps not speak for too long. I'm going to assume that people have read the slides and then we can have questions and discussion if that's okay. Does that suit, Susan?
Yeah, thank you very much. Yeah, brilliant.
Brevity, thank you. So at this point in time, we are 14 or so weeks since the pandemic hit South West London in about the 3rd week of March. And really, this is a really good time to pause and reflect on what's happened and consider the way forward. General practice has changed hugely in that time. Within just a few days, practice has radically altered their ways of working in a way that has never been required before. One of our colleagues just mentioned earlier that things might not be working quite as normal. There is nothing like normal in general practice at the moment. There's no normal anymore. what happened was a largely face-to-face and sometimes telephony-based service switched to being a largely telephony and sometimes video-based service. So it really just turned things on its head. Staff resilience was really tested, and in some practices at times there was a really skeleton workforce. Skeletal makes them all sound thin. Skeleton workforce. We adopted systems of remote working. IT hardware and software was pretty rapidly deployed, and we put new operating procedures in place. And over the next few weeks, primary care was, I think it's fair to say, bombarded with standard operating procedures, infection prevention and control requirements, and all the time becoming familiar with a kind of evolving clinical understanding of this really new mysterious condition. There was an absolute deluge of information and communication on all fronts. So as you'll know, as Andy just described, the primary care cell was established, and that was rapidly operationalised and became of central importance to the South West London response. And it's been really highly functioning, has resulted in a real team approach with managers and clinicians from all of the boroughs and the South West London team working together, I think, really very effectively. And in the boroughs, primary care networks, really only a few months into their existence, had this kind of sudden purpose way beyond what was expected at this point in their development. But they rose to the challenge, and in the vast majority resulted in a really accelerated progress, both within the PCNs, between the member practices, and between different PCNs, and with the local GP federations. And this was the kind of progress we thought might take several years to evolve, and it really happened very quickly. So as a result, there was local innovation abound, with remote pulse oximetry, hot sites and zoning, home visiting services, shared protocols and mutual support. So it was really excellent to see this stuff happening. And I'm talking as if it kind of happened easily. A lot of people worked very long hours to make all of this happen. So during this time, patient care has been much more digitally enabled and virtual than previously. Shielded patients have been supported, including by the new body of workforce, which is the social prescriber link workers. There were examples of cooperation between primary care and community services, and of note, GPs handled a vast amount of clinical risk because acute trusts basically turned off the ability of GPs to refer for some time, and that's only been reintroduced gradually, and diagnostic service is still not back to anything like normal. So there's a huge pent-up unmet need of both physical and evolving mental health issues, which are going to continue to have an impact way beyond this COVID surge. If you just flip forward to page 48 onwards, you'll see the recovery plan outline of how we deal with the next stage. So this is phase 2, and the focus really is on delivering services whilst living with COVID and with the ability to respond to future outbreaks. That means real attention to infection prevention and control and to safe practice. And remembering that general practice was in a very challenged position prior to all of this, and we've got to pay attention to the resilience work streams that were in place previously. That issue hasn't gone away. And we now have an understanding that in addition, many GP staff are at higher risk from coronavirus, including those in Black, Asian, minority ethnic groups. And that just adds to these concerns about the GP workforce. NHS staff are kind of understandably quite anxious about the risks to them in their working life. But there's a fantastic opportunity here to redesign and refresh general practice, embedding some of these new ways of working where they're effective, building on the changes that have happened. And we've got a suite of work streams in place, some of them described in this slide pack, to support the necessary work. And there's going to be more to come as we evolve our thinking and as boroughs develop their local plans. So the development of primary care networks is now an absolute priority to use the momentum that we've got and support primary care networks to establish their local integration of services. I think that's really important for how we'll be operating going forward. And we know that there are patients who have a higher risk of poor outcome from COVID, due to their diabetes, obesity, other conditions, their ethnicity. And we're going to need to support practices to identify and address the needs of these people as a priority. So this is in addition to managing the backlog of demand from people who didn't present in recent months and are going to now need care. So there's some really big issues to deal with. Changes of ways of working in secondary care have had a very big impact on primary care workload. And we're currently setting up a work stream to ensure that patient pathways are agreed between the acute and primary care. And then on financial resilience of general practice, I think this should be a huge concern. Really, the financial position of many practices may well be precarious. Some steps have been taken at national level to protect core income, but this by no means secures a position entirely. So the success of the next stage, I would say in summary, relies heavily on work that is anchored in boroughs, is coordinated and is supported at South West London, closely aligned to the work in other recovery work streams, because the interfaces between primary care and other parts of the system is absolutely critical in making the whole thing work effectively. So that was all I was going to say to start with, but there's lots of things in that slide deck that I didn't even mention. There's so much there really. So very happy to take questions and have discussions further.
Can I just first add our thanks to all the staff for all the work and the rapid change that's been put in place. And one of my issues is making sure that the well-being of those individuals is well supported, because people have had to deal with a lot of change and anxiety, and making sure that not only are we connected in terms of the patient pathway, connections between acute and community and primary care, but that we've got embedded in that a work stream which is supporting our staff in primary care to be resilient moving forward, I think, as well. So that was is that something that you're seeing as well, is setting in place? Is it some way of supporting the staff so that they can feel that they can move forward?
Yeah, no, so there has actually been a kind of a myriad of opportunities for people to take up support from the kind of, the mental health end of things up to just, support, supporting people to do their jobs more effectively in this difficult environment. So, the kind of the change management end of things and how people cope with that. Obviously there's a spectrum there, but there's been national stuff available and local stuff as well, and we've communicated that. So I think there's plenty of opportunity out there. I think a lot of people really just sort of battle on, actually, and it's making them realise that perhaps this would help you. That's always a challenge, but it is out there.
Okay, thanks. Les, did you want to pick up any points? Picking on you now, I see. You're muted. Jonathan, did you want to add anything while Les is sorting out his mute button?
Am I off mute?
Yes, you are.
Well, hopefully Les can find his way off mute in a moment. So I suppose I just wanted to emphasise, we sort of covered it in the first paper that we moved through at speed. And also reflected in Nicola's presentation, there's just the scale of investment actually that has been put in place across South West London to help address this. So there's been multi-million-pound investment in IT to move to this virtual way of working, for example, and the previous paper described a whole array of proposals put in place rapidly. So whilst we all recognise the fragility actually of primary care and the many challenges it faces, I did want to acknowledge as a member of the committee actually the scale of rapid decision making and investment that's been made, and say thank you to people for that, to deliver to this new way of working in primary care. So that would be my one comment, Susan.
Thank you. Right. Has anybody got any questions that they'd like to ask Nicola? Pick up on any particular issues that she's raised in her slides? Bruno, John, do you have any?
Yes.
Yeah, I do.
Okay, Bruno.
I think that going forward, there's a risk in all of this of a move towards effectively digital by default, becoming an inequality or creating an inequality in and of itself, which will impact on health. So it's just whether or not the potential for that happening is something which is being kept clearly in mind as things go forward, because we certainly hear from people that there are communities and individuals who have much less access to digital technology, and I know that the intention is to triage rather than to have purely digital services, but I just wanted to make sure that that is being kept clearly in mind as things go forward.
Yeah, so Bruno, that is absolutely right, and it's something that is being discussed all the time. So I wouldn't say that we've necessarily got to the place where we can describe what needs to happen, but I think there's a huge awareness of it. And I kind of like to think of it like this: before all this happened, what we were saying was there's a massive demand on general practice, and there's a danger that at some point it will no longer cope. And so what we do is to use the power of technology and virtual consultations to enable people who can to use those mechanisms in a more efficient way, so that frees up more healthcare access for those people who can't. So as a GP, I can dispatch with the stuff that can be done efficiently and quickly in order to spend more time with the people who need it the most. What then has happened through this phase is that the mechanisms for doing the digital stuff have been deployed really much more rapidly than we could ever have hoped. But the danger is that becomes the term digital by default was not our South West London one. That is the national term that's being used. And I think we just need to make sure that we're actually deploying that so that we can spend more time with the people who need it. So we've got to kind of mold that back into what the intention was, I would say. But it was very much needed in general practice. And so it is a good thing, but one of the things that we want to make sure is that it doesn't become this inequality. So yeah, please keep saying that. Please keep challenging us on that. I think it's really important.
John, you wanted to make a point.
Yeah, I mean, I guess my point was related to the point that Bruno was making. I mean, the page 48 of the pack refers to both designing, implementing and embedding these new ways of working. Given the scale of investment that some of our GP colleagues have mentioned, it's clear that these new ways of working are going to be around, if not permanently, certainly for a very, very long time. And it's important that the PCMGs in particular, I guess, are able to learn from the data that Healthwatch has got about the patient and public experience of those service changes, which is not just a communications issue. It's about actually understanding what patients are finding out about these services and perhaps adapting the new services to meet some more of the needs identified by patients to Healthwatch in that process. And I guess there's a more general point here. I'm sorry to keep saying this, but while the level 4 arrangements are not allowing us to function properly, some the not usual or the not business as usual involvement of Healthwatch in some of these key decisions as they're being made and designed is a real pity.
Nicola, you wanted to come back on that?
Yeah. So John, I think you're so right. We do need to understand the impact on this on which patient groups are going to be disadvantaged by it. So we do need to do some work to clarify that, and insights from patients and the public and from Healthwatch, etc., are absolutely critical. Just to also say that we think clinician education is really important as well, because some doctors are great face to face, but can't really do as well on the phone because they were never taught. It was just one of those things that sort of happened. I don't think we should let that happen. I think we need to make sure that people have good telephone consultation skills and good video consulting skills. So we're sort of winding back now to say, well, let's make sure we've got those fundamentals in place at this point, including all the governance around information technology. And things like safeguarding, which, safeguarding is often, a very big part of what we do as GPs, big pieces of work. It takes on another dimension when you add in video consulting. We didn't have to think about that before. So we're trying to get at this from every angle. It really is important.
I think Les has joined us back again. Did you want to ask a question, Les? Welcome.
Yes, apologies. My computer decided to do an update on its own. Anyway, which goes partly with what you were talking about. I'm concerned about secondary care doing a lot of video and telephone consultations, and the result of that being a pushback to work for primary care, as they're not seeing the patients and not getting the tests and bits done at in the secondary care level. And I think probably there's going to be, oh, go and see your GP, they can give you this or do that for you, which is the responsibility being passed down to primary care. And I'm wondering how that's going to be solved, really.
Yeah, so I mentioned that in my presentation, actually, Les. I think you might miss that bit, but so it's really huge, actually. So
Yeah.
so people kind of understand. You get correspondence from a patient in outpatients, and it kind of explains what's going to happen and might mention a couple of things that possibly you could assist with. Most letters I now get, you know, a to-do list of 6, 7 or 8 things. Please, would the GP do this? And it's because of new ways of working in secondary care that haven't quite worked through, and the technology hasn't quite worked out yet. So, you know, it's not an intentional thing from a consultant's point of view. It's just something that's happening in the system. So recognising this, and I think it's really important that we do make sure that we utilise general practice where it's most effective. And to some extent, this might be part of it, because it might be that it's better for patients if some of this stuff was done in general practice. But we need to make sure that that is planned, organised, that we have agreements between acute and primary care on what the pathways are and what we can all expect from each other as professionals. So we're just setting up a work stream. We must have had 4 meetings in the last week where we're talking about how to manage this. So it's very much on our radar, not sorted yet, but will be.
Right.
Does anybody from the boroughs or the LMC want to pick up on any
Just nothing. Andrew had his hand.
Sorry, who was that?
I've seen Julius has his hand up from the LMC.
Right.
Yeah, thanks very much.
you.
I think that was a really helpful point, Les. And in fact, it was discussed by both LMCs with the CCG on yesterday at senior level and several times before. We're really concerned that, and I can't share Nicola's optimism here, it's not just due to inadequate systems. That is part of it. But part of it is that the changing way that the hospital is being paid under these pandemic arrangements means that there isn't the incentive now for them to undertake work that they would normally do. And I agree with her. We've had lists from GPs where they've received letters from consultants telling them to do 8 or 9 different tasks. And this is absolutely inappropriate, and it's overloading general practice at a time when, as she's described vividly, it's completely stressed by multiple different sources of work at present. So this needs to be addressed much more actively than simply recognising that it's important and thinking that there needs to be some new pathways. It may be convenient and more appropriate for patients to be seen in their general practice or in community, but unless the resources, and that means both money and staff, are provided, then it's simply going to sink the system. This has been raised nationally as well with NHS England, but I think it's one of the most risky parts of going forward. So I would wish to re-emphasise that point.
Thank you. So who else was on the? Jonathan, I can see your hand.
Yes, so I just wanted. I was in that conversation that Julius had and Asia and a number of us had yesterday, and it is a really important point. We just this morning actually we had Nicola and myself together with the medical directors and some GP colleagues, including Naz. We're talking through how we were going to begin to scope that piece of work, and you know we understand there will be incidents where things aren't as they should be, and I think we all have to sort of beg a bit of forgiveness for the system whilst it's going through the changes that it's going through at this point in time around that. But just wanted to reassure people that with Nicola, Naz and Ruth Charlton, who's the Medical Director of Epsom St Helier and the Deputy Chief Exec there, leading that work, I'm hoping that we will have a coordinated plan emerging over the coming weeks about how we're going to manage this together that doesn't bring undue burden to primary care, but also protects patients and treats them in the right care setting. So that's the balance that I think we'll be seeking to achieve through that programme of work. And I'm sure there's some slides that Naz and Nicola presented this morning, and we can share those with members of the group to keep people informed about how that early work is progressing, if Nicola's comfortable with that.
Yeah,
I'd be very keen to see those, Jonathan.
Yeah.
Just because, I mean, this was a subject of many quality alerts and things in the past, and of course, moving forward, it's not going to change back. So I think it is incredibly important.
Okay.
Yes, and we do need to work it through, and we also need to work out, what is going to change back, because some things will have to, and what things need to stay where they are and be appropriately remunerated and responded to accordingly. So that's work in hand. It's in the foothills at the moment, but hopefully people will be aware that through the work that we've just outlined, we're starting.
Okay. Andrew.
Thank you. I think it's just worth reflecting on the amount of change that has happened over the past 3 months. I mean, it's been absolutely phenomenal, really. And I think we need to just place on record our thanks, not just to obviously the primary care staff, the practice as well, but also just to sort of my team and the borough teams as well. I know William, Katie, Sean, Bobbin and Mark have worked incredibly long hours to do the amount of change that they have. So I just want to place on record my thanks to them as well.
Yes, of course.
As Nicola said, this is very much we've done the first phase. Now we're kind of into the new normal phase, which will take some time to adapt to and adjust to. But I know that with the support of the number of people we have in the system, including the LMC, I've no doubt whatsoever we will get there.
Okay. Do the boroughs want to add anything? James,
Yeah.
Lucy?
Sorry, Mark here.
Yes, hello, Mark.
I didn't have my camera on. It was just to basically say that the work at South West London is obviously replicated at a local level, and there are different forums certainly within Croydon, whether it be the outpatient transformation work stream or the recovery board, but absolutely the not being dumped on conversation is very much live at a local level as well.
Thank you. Anybody else? Tonya, Lucy?
Bruno's
James?
got his.
Bruno.
Yeah, I was just wanting to mention that we know that before the epidemic, there were concerns about the voice of primary care within the integrated care system, and it sounds like those are to a small extent here playing themselves out. But I think that needs to be a key kind of focus going forward once it's possible to really focus on the functioning of that and the way that primary care has a voice within it.
Okay, James, did you want to say something?
Yeah, I mean, I think I'd absolutely agree with that. I think that's something we're working through, and I think that the how we structure that both within recovery and within long-term integrated care system discussions is really important. There's LMC representation here today. There are also our primary care networks, and there are also our GP federations. So I think reflecting on primary care and general practice provision and how we ensure that plays into these various types of discussions is really important. And I think that also, what I think is reflected from this discussion is the variety of primary care across even 6 boroughs. Some of the issues are generic to primary care as a sector, but local context and the local structure of general practice is quite different as well. So I think that's a really helpful challenge. It's one that is being actively picked up at the moment to make sure that we get that in the right place.
Okay, thanks. And I can see Lucy and Tonya are supportive of all that's been said so far. Right. Anybody else got any questions they want to pick up with Nicola? Or any comments? No. Right. Well, thank you very much, Nicola. Great in-depth review, and congratulations to everybody on what they've done, and good luck as we move forward, really. Yes. Okay, shall we move then, probably helpfully, onto the Borough Primary Care Management Group reports. So this is the covering a whole range of issues in terms of the contract information and as well as the COVID. If we're going to go through, I'm just going to pick on a borough, and if you're happy just to work through that process, or we could go through them in the order that they are in the papers. Would that be the easiest way of doing it? Let me see if I can call up the right papers. This is where technology and me. So who's the first in line, Andrew? Is it
Croydon, Chair?
Croydon. Okay, Mark, did you want to pick up any? Obviously, people have read the papers. Is there anything particular?
Yeah, so I'll take them as read. I suppose probably just picking up on some of the conversations that we've had. So one of the first things we did at the primary care management group was to look at the terms of reference. Are we getting the governance right? Are we feeding into Southwest London? But also making sure that at a local level, we are kind of making sure that we're feeding into our integrated model of service delivery. I think the review of the SOP and the IPC rather was central to our.
Do you want to explain an ICP to people in case they're not familiar?
So the infection prevention and control guidance that's come out. So actually we had quite a long debate about what the impact on that would be for our local GP practices and how we would support those GP practices in getting being compliant with the IPC guidance. And we're doing some work on that at a Southwest London level, and some checklists were sent out last night. We talked about some CQC reports, just basically in terms of some practices, about the actions that we were taking to support practices in improving their CQC rating. And then launching kind of, we paused our locally commissioned services in line with everything national, but actually how we were going to kind of restart that and restart the conversation about the delivery of some of that activity. I think for Croydon in particular, there was a lot of debate around the care homes, and I know there's a public question about care homes, but really because we've got 130 care homes in the Croydon patch, we spent some time just in terms of what is the strategy going forward in a COVID and non-COVID world going forward, and some of that's related to the development of our PCNs and also the PCN DES. So that's kind of the summary of what we discussed at the primary care management group.
I don't know whether this is putting you on the spot or whether you can respond to any of the points that made earlier about how we hear the voice of local people in the discussion moving forward, albeit we haven't had a sort of formal delegation.
I think certainly in Croydon and at a Southwest London level, I think we're acutely aware that that needs to be strengthened. Within Croydon, we have an integrated management team with the trust, and so therefore there are different boards and different committees that we want to review and make sure that certainly Health Watch and patients are represented effectively on those boards. I think the thing to say with someone mentioned another borough that did have Health Watch. I think one of the things we were keen to do in Croydon was, as we've come out of the kind of the COVID panic, so to speak, there is something about us looking at who is represented on each of the borough-based committees and groups, and actually making sure that we have got patient representation and community representation effectively on that. So we are continuing to kind of review our terms of reference in the light of the rest of the governance structure kind of beginning to land and beginning to get into a rhythm.
Yes, and obviously the voluntary sector, not just there representing a voice, but a provider in partnership with you, really, in terms of how you might.
They're very much part of kind of the One Croydon Alliance, but to make sure that that also filters into the primary care working group.
John has asked in terms of clarity on a stakeholder engagement plan, and so sharing that would be, that's quite a useful way forward, isn't it? Describing how you're going to connect with all these.
And again, at Southwest London level, I know that our comms and engagement team are really keen. They've been working with the primary care cell to kind of feed out as what has been collected through COVID in terms of the patient voice. So there is a work stream underway to kind of like strengthen that now that we are in a more kind of recovery stage.
Okay, thank you. Anybody got any urgent questions? Otherwise, if we move on and then perhaps come back to.
Sorry,
Mark.
There were two public questions. You want me to do those?
I'll do those at the end if that's all right, Mark. Yeah,
fantastic.
Thank you. Right. So then, anybody want to pick up anything particularly with Mark, or should we move on? No. Right. Okay. And so the next borough is my report is Kingston Enrichment. So that's Tonya. You said you were going to give us.
That's right. Thank you, Susan. And I'll take Kingston Enrichment together. And again, as Mark has said, I'll take it as the report is read, and I won't dwell on those areas that we're in common around IPC, SOPs, and a restart of LCSs. So the two areas that I really wanted to pull out from the paper was the merger between two GMS practices, Groves New Mordaunt and the Groves Hinchley Wood merger. Hinchley Wood is actually in, I don't know, are they still called Surrey Downs? In Surrey. So actually there is, and I think there is, a risk around the merger, not so necessarily on the GMS merger, but the wider commissioning risk for I think about 6,000 patients registered with that practice and what that means. So we are working through that. The planned merge at the moment is for the merger to happen beginning of next financial year. So we're working through that, and of course we'll keep the committee updated on those discussions. The only other thing I wanted to say is thanks to the practice in both Kingston Enrichment for an outstanding CQC report, and I think you can see in the report that in Kingston 100% compliant and rate is good overall, and the same now in Richmond. So I think that's a fantastic achievement. So I'd like to thank the practices in Kingston Enrichment for all their work to be able to make that standard. So other than that, you say the paper's there to be read. I'm happy to take any questions. So did you want to talk the patient and public?
Yes, that would be good.
Yeah. So we do have health and watch, as we've already said, on our primary care management PCMGs, isn't it? So they are there. They also have a place around our place committees and our borough committees. The thing is that place committees in Kingston and Richmond aren't meeting at the moment. It's just not seemed to be the right. It hasn't seemed to be the right thing to do in Kingston and Richmond. We are having conversations at the moment about how do we restart the work, and we are starting to have those conversations in both Kingston and Richmond. And then we, like Mark has said, we're looking at the terms of reference to make sure that the engagement we have and the contribution we have is meaningful and effective. We have also started our broader comms and engagement plan with our PPE leads. So we really want to encourage a broad engagement and feedback and a contribution from the public. So we have started that because, as Mark said, now we're going more into a more stable, I would say normal, but more a more stable environment that we can start really thinking about how we improve on our engagement approach based on what we've learned through COVID.
Okay, right. So we'll need to keep cited then on the merger issue, but yes, congratulations on all the work in terms of the CQC. Right, Sutton, who's speaking on behalf of Sutton on the paper?
Hi, Susan. Yep, that's me.
Sean.
Turn my camera on. Hi, yeah. So likewise in Sutton, we had a conversation about some contractual issues and the local incentive schemes, and we also, because we met just after the network DES sign up, we acknowledge the new that our practices have signed up to the network DES. We will have a change in clinical director because one of our clinical directors is moving out of the borough. In fact, he's moved now, and he's been replaced by another nurse. So we now have two nurse clinical directors in Sutton, which is really good to see that sort of high-level leadership from our practice nurses. We discussed our practice incentive schemes and PMS KPIs in the context of the COVID response, and we'll be having to make some changes to those KPIs, which aren't really relevant in this new world we find ourselves in. And we had a long discussion at our meeting about the recovery model going forward. Our PCN clinical directors have shown amazing leadership over this really difficult period. They have led the creation of community response teams to really promote integrated working across all stakeholders, and we sort of need to make sure we keep hold of that really good integration and collaboration, but at the same time moving on from a sort of very reactive model of primary care, which rightly so, you know, that's what people had to do at the start of the pandemic, but really looking at how we pick up some of the more proactive and preventative work going forward in the context of the standard operating procedure, so making sure that services are delivered safely, both for patients but also for staff as well. And then finally on quality, we discussed having the first meeting, which will be scheduled shortly, just looking at quality in primary care. So I suppose linking in with what I just said, particularly around the SOP and making sure that services are delivered safely and to a high standard. You know, the model of primary care has changed. I think, you know, back in January, none of us thought that primary care would look like it does right now in such a short period of time. And but we need to ensure that it's a quality service and again, linking back to what was said about sort of inequalities as well, making sure that it's accessible for all patients, even if they can't make use of some of those new digital services.
Okay, thank you very much. Any questions for Sian, or should we move on? Is it Catherine? You're going to talk for?
Hello, yes, I will lead off for Burton and Wandsworth. So, as others have said, I won't dwell on kind of the common discussions that we had. The bulk of the meetings, as they were initial meetings, to be honest, were focused around terms of reference, bringing the group up to speed on the changes that have taken place as a result of COVID, and talking about LCSs and how we restart those as well. But just a few key things that I thought I would draw out for you. So from a Merton perspective, we had quite an in-depth conversation about some of the practices CQC reports, and in particular a number of practices that were sort of on our radar prior to COVID that we'd been doing quite a lot of work with to try and support them to improve following their previous CQC reports. We were quite pleased to see that there had been some improvements in a couple of places. And we also talked about the PCN DES. Again, in Merton, we were really pleased that all of our practices have re-signed up to that in a broadly similar configuration to before. So there were no significant areas of kind of discussion around that, but we were pleased that that seems to be progressing. From a Wandsworth perspective, I just wanted to flag that there is one practice, as noted in the report, that hasn't signed up to the PCN DES this year. We've done quite a lot of work with that practice to try and explore their reasons, but ultimately it is an option for them. And we are now pursuing discussions with the local PCNs to make sure that we can ensure their services, the PCN DES services are offered to that patient population as required within the contract. The other thing that we talked about in particular in Wandsworth was a review of activity that's taking place at the Junction. So the Junction is a practice and a walk-in centre and an access hub situated in Battersea. And we just wanted to reflect, given the changes that have taken place as a result of COVID, what groups of patients were still accessing that. And it was interesting to note that actually there are still a number of patients outside of the borough who are making use of that service, as well as our local practices as well. So that's something that we'll be taking forward to inform how we shape that service in the future. The final thing, so slightly different to what some of the other boroughs are doing. So we've had in Wandsworth and Merton a joint primary care quality review group operating for a few years now. And we restarted that last month following a couple of months break as a result of COVID. The bulk of the discussion from that was focused around what information we need to be looking at and reviewing in the coming months, and actually what information we have available to us to help inform conversations around quality in primary care, particularly given a number of the sort of traditional mechanisms of reporting that we might have used prior to COVID have been switched off for a few months. We also talked about CQC reports and had a discussion about how we might best deploy our practice support team resource in the coming months to support practices around some of those areas that we know are going to be tricky for them, for example, delivery of the new infection control standards and those practices that we know are struggling or anticipating a CQC visit in the near future. So I think that's probably it. I'm happy to take any questions.
I was just sort of picking up the point about the sort of patient voice. Can you just remind me, because also it was picked up by John in terms of the quality groups. They're slightly different structures in different areas, but it might be helpful just to think about how.
Shall I?
Oh yes, thank you, James.
I'll come in there, Susan. So we don't have Healthwatch representation on the PCMG for Merton and Wandsworth. I think as Katie's outlined, in the way that we're using the group at the moment, I think it's from our perspective, it's largely an internal business meeting. It's being used to formulate policy, and it's also being used to discuss a number of confidential and sensitive issues. I think that is a decision that we've made in the context of having running place committees with Healthwatch involvement in both boroughs. We've also had for a number of years a clinical lead for PPI in Wandsworth CCG as a legacy, who is very involved with a number of PPI forums, including a Thinking Partners group and including a PPI reference group, and regular senior primary care involvement with liaison meetings with Healthwatch. And it was our intent pre-COVID to extend that clinical lead for PPI post across Merton and Wandsworth, actually, because I think that for me, what's really important about public and patient involvement in primary care is that yes, absolutely, it happens around place, but it also happens at practice level, which I think is something where Wandsworth has really led the way, really, in terms of the work that Sean, our lead, has done. So it's something that we're happy to keep under review, but it's not something we would plan to adopt at the current time.
And I think that's an important point, James, isn't it, that the boroughs need to work on a system that operates best for their communities. So different structures will emerge, but making sure that we've got the dialogue in place, we've got the connections and the networks with our patient voice organisations. I think that's the important thing. And it's just, from our point of view, getting oversight that does exist, and it may look different in different places, but the important thing is the impact it's having for your services. Okay. Has anybody got any questions for Catherine, for Mark, for Tonya, and for Sean in terms of any of the papers that they want to pick up? No? Well, thank you very much indeed. That's really helpful. Sorry, Nicola, yeah?
So we just missed the quality question. I wonder if it might be quite important to understand that. I think Andrew's probably going to. Yes, there he is.
So I was going to actually just go back to one from John at 10:48 around stakeholder engagement plans, which is in specific relation to the online consultation procurement that we're doing. So that's page 57. So I just wanted to say we have got a whole range of patient stakeholder events and workshops planned. And details of those will be put out through you and with Healthwatch very, very soon. And in terms of the borough transforming primary care separate question on page 60, I think this is down to the overall recovery governance and recovery structure. So I think what we will be bringing back to future meetings, no governing body meetings, is a bit more detail about how the recovery or the return to new normal approach will work. But again, we're absolutely committed to that borough engagement, because as I've said before, we're very much reliant on our boroughs to make sure that we get the best quality general practice as we can do, and obviously want to make sure that we deliver it within South West London principles. And then I'll just look on the next one about the quality groups. So I think I talked in the governance section, I think it was section 6 of the first section, around sort of quality matters. And I think what we want to do is bring back, perhaps this next meeting, just a kind of a collection across South London of how we actually look at quality surveillance and what do we mean by quality in general practice actually, and primary care. Each of the legacy CCGs have been having various quality oversight scrutiny meetings over the past few years, and as Katie said, these are just starting again in the context of COVID. And what we're trying to look at clearly is to try and get some consistency across South West London. But I'm very pleased that I think all of the boroughs have, if not a quality clinical lead, then they have a lot of meetings with clinicians where they can specifically look at some of the data and intelligence that we get, and some of the soft intelligence. And I know that they're also very proactive, working with practices and with federations to try and support any vulnerable practices or groups of staff that need support at certain times, and to try and be very proactive with it. And I think that's largely reflected in the results of CQC. that we've seen in PCMG, that we have a really good standard of general practice in South West London, and we absolutely need to make sure that that is maintained. But I think what we will do across South West London, just so this committee in public has an oversight of it, is bring back the summary of how we talk about quality surveillance, and actually the various touch points within that as well.
Okay, thank you. William, you haven't added anything into the conversation, did you? With your role, did you want to add anything? Or?
No, Chair. So a lot of you'll see the borough reports have incorporated a lot of the South West London contracting functions that we've done. So the teams have presented the work that my teams have been doing in now we're one big team. So there's nothing really more to add, Chair. Thanks.
Okay, good to see you. Thank you. Right. Any other points that I've missed by not seeing hands raised or voices heard? Okay, great. Thank you very much. Well, can we just then note the contents of the reports from each of the boroughs then for the minutes? Now that we're now on to public questions, we've asked people to write in advance because we're not holding the meeting in public, and we've had 2 questions. They're both around Croydon. The first one is about access to data on child immunisation, in particular information whether any reductions in immunisations during the period up until June, and what measures are being taken to encourage and reassure parents and carers to keep to vaccination schedules. Mark, did you want to pick that one up first?
Okay, so I won't read our answer verbatim, but I'll pretty much stick very close to it, just so that when it's the minutes are issued and it matches my narrative really. So we don't currently have access to the comprehensive immunisation data covering March till June. However, we do know that immunisation coverage across London declined from about 25%. NHS England has obviously focused on a number of priorities around the recovery and catch up on vaccinations, primarily in childhood vaccinations, but also in maternity, pneumococcal, and priorities such as BCG and hepatitis B. In Croydon, we're continuing to work across local partner organisations in the immunisation steering group to address our local priorities, particularly MMR, BCG and Hep B, and then flu. And we have a local measles elimination action plan in place to kind of facilitate and coordinate activities across a number of partners. We've got a task and finish group now, and we've been working with that over the last 3 months to focus on children, looked after children, to make sure that there's optimal take-up of immunisations and vaccinations there. And we're exploring alternative models of delivery, and I emphasise the exploring alternative models of delivery, basically in a COVID world, such as drive-through or mobile kind of vaccination units or drive-through units, but we are just at the investigation stage there. We've set up a task and finish group to contribute to the Croydon seasonal flu plan, based on Pan London and also within the context of COVID-19. So that's probably all I'll say in terms of immunisations.
Thank you. And then the second question is also for you. It's about clinical leads for care homes. They're aware that a considerable amount of valuable virtual and telephone communication is going on during the pandemic. Just asking to what extent have clinical leads, GPs, been able to visit care homes to assess medical needs of residents?
Okay, so I suppose, again, within kind of the NHS guidance, the general practice is working on a kind of triage system and remote consultations where it's appropriate, but where it's appropriate and safe to do so, or clinically necessary, there have been face-to-face and visits to care homes. The model has been applied to all of our care homes. We now have clinical leads identified across all the care homes, and there's a pharmacy lead in place, and MDTs have been established as well as the weekly check-ins, which was a requirement through COVID. We don't hold data on the number of face-to-faces in care homes at the moment, but we are aware of our GPs and our care home staff working together to make sure that the necessary medical care to residents has been accessible. And we have been clear that GPs are expected to visit and arrange a visit with the appropriate team if it's deemed clinically necessary. We always had in Croydon weekly check-ins with nursing homes and monthly check-in with residential homes, but obviously with COVID, that has increased, so we are doing weekly check-ins across the board. In Croydon, we've implemented IT remote consultations with health services since December 2018, and the telemedicine service exists in 75 out of the 130 care homes. Most of our care homes were obviously didn't want external visitors, and have kind of welcomed the expansion of remote consultations during COVID. But we have the ability for them to access GPs hasn't really changed. We've done a recent survey. 94% of our care homes stated that they felt they had adequate and good access to primary and community health support, and we have targeted the other 6% to make sure that we are linking in with them. We've integrated a GP with our rapid response team to help with admission avoidance, but also expedite discharge pathways, and added medical capacity into the MDTs to make sure that people remain at home in their care home. That's all I'll say on
That's very comprehensive, thank you. Lucy, you wanted to make a point, I think.
Well, just to say, yeah, really comprehensive and a great answer from Mark, but to also emphasise there's been a South West London work stream around care homes, and that has complemented the great work they've been doing in Croydon by ensuring, for example, that every care home has...
Sorry, I've lost you, Lucy.
...has access to data, GP practice and care homes, and a range of other initiatives like that.
Okay, great, thank you. Right. So I'm not aware of any other business. Andrew, is there anything else that we should be covering today? I have to apologise that we're only 11:15 and the meeting goes on to 11:55. So I apologise for stopping too soon. But thank you very much for your time. And
Someone's a very grateful chair.
No comment.
It's always best to set the agenda so that there's plenty of flexibility, isn't there?
I'm very pleased. I've got another meeting to go to right now.
Can I just ask, we have a part 2 meeting, which was set for later. Is there any chance of bringing that forward so that those who need to be part of the part 2 could meet again in another 5 minutes? Andrew,
Yeah,
would that be all right?
Yes,
okay.
Thank you.
Well, thank you very much, everybody. Sorry, anybody else want to say?
Just to say, we have the next meeting of the Primary Care Commissioning Committee in public is on September the 16th.
Thank you, Andrew. Okay. Right, well, thank you very much, everybody, and see everybody in part 2 in a little while. Thank you. Bye-bye.
Bye.
Thank you, Susan. Bye.
Bye.